It is a great privilege of mine to be here and to kind of help host the next hour or so of our time with Dr. Saurabh Sha. But before I get to that, I do have a couple of housekeeping items that I just want to make sure I pass on. So the first is that um, I hope you guys will all consider and vote very carefully for the Best Poster Award. There's a chat link that will show up where you guys can go and make your selection. That will be open up until about 2:30 or so, after which we'll tally the vote and then announce the winner after the panel that concludes at 4 p.m. today. So that's item number one that I was told to make sure everybody stays on task for. I think the other important aspect is that Jenna had also made a point of suggesting, where was that message? That you can use the Q&A function at any time throughout the talk, but what we'll do is we'll gather those up and then we'll have a discussion with Dr. Sha as soon as his talk is done. And so without further ado, it's my great pleasure to introduce Dr. Sha. He's an associate professor of radiology at the University of Pennsylvania. He completed his medical degree at Guy's Hospital in London, dabbled in surgery for a bit in England and in Outback, Australia. He switched to radiology and emigrated to the United States, did his residency in diagnostic radiology and cardiovascular imaging at the University of Pennsylvania. He's a prolific writer. He's also a bit of a rock star and wit on Twitter, where he goes under the handle of @RogueRad. I suggest all of you follow him. He's quite entertaining as well as educational. He writes a lot about medicine, policy, culture, and of course, artificial intelligence. And I also recommend that you put him on the short list of folks that you read anything that he puts down on paper. So Saurabh, it's great to have you join us here. And we look forward to hearing your talk.
Thank you, Brahmajee. Thank you for the invitation. Be nice to have been there in person and have drunk craft beer with you, but virtually is also good enough. So the title of my talk has morphed a little bit, because I realized when I spoke about algorithms without borders, I was really talking about only one indication, which was tuberculosis. So I'm going to talk about AI and TB, and I'm obviously a little nervous talking about AI to data scientists, because I don't have any computer science background. I don't even play a computer scientist on Twitter. But I hope you'll realize one thing, which is something I want to get out from this talk, which is that how radiologists practice their craft affects algorithms. That goes without saying. And the other thing is that how algorithms end up performing is a reflection of radiologists. And I hope that this dialectic will become evident. I do actually have a conflict of interest, which is important for me to mention. I received travel expenses from Fractal, which is the company that nurtured Cure AI, which is one of the companies which is the company I'm going to speak about. Not in terms of what their general market share and everything else is, but rather in terms of the rationale for the product. So this is relevant. And I will say one thing before going further, is that there are three major vendors in this space, in the TB chest X-ray AI space. Cure AI is one of them, and there are two others, CAD for TB and Lunit. And a study was done, which was published in Nature back in 2019, which shows that there is no difference between the three of them. Their AUCs are merge imperceptibly. So I could be talking about any one of them, but it was important to get to the bottom of one particular vendor, which is instructive in many ways. So just to give you a little bit of a background, I think you should know a little bit about me to understand why I went about what I went about doing. So a few years ago, this was a very famous phrase from Jeff Hinton back in 2016. Quite obvious, we should stop training radiologists. Radiologists are like the coyote already over the edge of the cliff who hasn't looked down yet. This was a a brilliant analogy. Couldn't have come up with a better analogy, meaning that the technology is so far advanced, the algorithms are so far advanced that it's too late for the radiologists to look back. So we're off the cliff. This was said in 2016, and it's one of those famous last words which is both amusing and will amuse Professor Hinton, may even haunt him a little bit, because 2020, we're not in that situation at all. In fact, at the time in 2016, there was a lot of excitement, a lot of hype that naturally comes with the excitement. A lot of money was being put towards AI. Vinod Khosla, the venture capitalist, the alpha venture capitalist, said that it's not just radiologists, but 80% of what doctors do can be replaced by algorithms. And so there are a lot of these sort of pronouncements at the time. And what I did at the time, around 2015, was I did my own kind of searching for what exactly this is. And I must admit, I was impressed. I was impressed because when I went to the RSNA, I saw feats that I thought were impressive. Like, for example, IBM showed me one of their algorithms, which was picking up pulmonary emboli very easily. So, you feed it in and there would be a filling defect in the lobar artery and it would go right there and point it out. Of course, there were nuances. They used their best images in order to showcase what the algorithm did. The best images in the patients that were the leanest, who had the most obvious pathology. Nevertheless, it was still quite impressive. And I was, I'll be honest, I was a little afraid. I thought, wow, this technology should not be ridiculed. This technology can do stuff and can do some of what we do quite easily. And so in my own kind of discovery, I went around, I wrote a couple of pieces. One was, will computers replace radiologists? And I remained fairly parsimonious. And like a typical radiologist, I said, probably not, but it can't be excluded, can't be ruled out. I also joined forces with another futurist, Eric Topol, and we came to the conclusion that it'd be good if two information extracting fields, radiology and pathology, joined forces and became one. Partly because of AI and partly because of something that they should have done or should be doing anyway. So, with information, there are fields that are primarily patient-facing and primarily not very patient-facing. Radiology and pathology happens to be one of them. And our major job really, and the similarity is that we're there to extract information and give that information to the clinician who can then correlate and join those information sources. Recently, I put out a post with a medical student in Knowledge of Wharton, which had a rather ironic title, which was Saving the Robot Radiologist. Ironic because in that we concluded that, if radiologists don't adopt the technologies, then AI vendors are going to be obsolete. And the current pandemic doesn't help that. That doesn't help matters. I'm going to try and keep COVID-19 mentions to a minimum because everything seems to be in times of COVID-19. And I was challenged by a researcher from Canada, Sarah Melville, to bring COVID-19 in. And I said I wouldn't, but now I've done it anyway. So it's kind of like a personal joke, but the point is that this year, the pandemic has done many things, including the major vendor meeting, the RSNA, is now being held virtually. And you can imagine the losses that companies are going to face, particularly startups. So far from replacing radiologists, radiologists are now, being conscripted, or should think of making sure that this technology doesn't go for waste because it's useful. And why is it useful? It's useful because one of the traps that I fell into, and many people fell into, was this Anglo-centric way of looking at AI. And this is something which the venture capitalists are responsible for as well, them and all the money that goes. And the money goes whenever you mention the word replace, transform, disruptive innovation. Oh, here's $1 billion check. But what about that simple word, supply? How about instead of replacing radiologists, you supply radiologists? Because in most of the rest of the world, which is something that Dr. Rao, who is head of research at Cure.ai, said to me, in most of the rest of the world, there aren't any radiologists to replace. So this kind of fear is just pure first world agony, where radiologists worry that their salary may go, they may have to work harder, or they may not have a job. And it's so different to parts of India where you may well get at the technology there, but you won't get a trained radiologist to go there. Trained radiologists want to stick to cities like Delhi, Mumbai, Bangalore, because those cities have good education, and nobody really wants to go to rural India. So that's really where the challenge was. And once you think about AI in that manner, it changes the way you look at it. So last year, I began to take an interest in chest radiographs and tuberculosis, and naturally with AI. So why TB? What's the great deal about TB? Well, as I'll explain, that as chest X-rays came about, one of the first indications came for tuberculosis. Tuberculosis, to recap, is a disease that's been there for eons, one of the oldest diseases known. You can find references to it even in the Old Testament. A lot of famous people had it. I can give you just a bunch of examples, like George Orwell, Emily Bronte, the Hunchback of Notre Dame. The Hunchback was, of course, the gibbous deformity from TB of the spine. It was once thought to be a disease of famous people and a Bohemian disease, and then now it's become a disease of poor people. And it's still the leading infectious disease cause of death, 1.6 million deaths. And again, the pandemic, which I guess can't get away from mentioning, has created a squeeze on this. So I would expect that because the screening has reduced, and because the focus is so much on COVID, that these numbers are going to be higher next year. And the WHO wants it eradicated by 2035, but this isn't quite like eradication of smallpox, because the vaccine isn't as good. So there are other ways that you have to get to the eradication. So where does the chest radiograph come into it? So in November the 8th, Roentgen accidentally discovered X-rays. He was playing around with the cathode ray tube, and he wasn't looking for things to glow far away, but once he saw it, he immediately recognized that he's dealing with another sort of ray. This actually happened on November the 8th, and this year is going to be the 125th year of the discovery. Now, that happened in the latter half, or the end of 1895. And remember, this was the time before knowledge disseminated widely. Right now, anytime something comes on, Twitter's on it instantly. This was back in the, towards the twilight of the 19th century. And so it's very impressive that within 6 months, a physician that had a bit of an engineering background and kind of an engineering mind was going around fluoroscoping chests to look for TB. And TB was the disease that they were looking for, because it was recently discovered to be due to a bug. Physical examination had also improved, so you were able to correlate. It's very hard in imaging to make any progress unless there's something to correlate to, either the physical exam or the microbiology or the pathology. And at that time, the physical exam had just had just emerged. But it was still left just to enthusiasts and actually didn't kick off. And in fact, what happened was that around the time of World War I, which is about 20 years later, X-rays had got to the point where their use was quite well understood, but they were mostly around to locate shrapnel, because surgeons were more likely to explore if you told them where the bullet was. And it was quite ironic, because around the time, the soldiers in the First World War, a lot of them, they had TB and they infected each other, and there were a lot of collateral damages from friendly fire from the TB itself. So there were lots of problems. One was the exposure was quite high. As time went on, the radiograph developed into people's imaginations. This whole idea of X-rays being able to see your inside. Book that got the author the Nobel Prize for Literature, Thomas Mann. There's a lot of it about the chest X-ray, which is kind of like, a good luck charm. So it was about a TB sanctuary, and patients used to carry their X-rays with them. And he describes it very well: lenses, switchboards, glass, diapositives. And he talked about it being the technological witch's kitchen. It was just enigma, it was magic. So advances were made, and towards the Second World War, a case was made that screening for TB is something we should do. And screening by definition is going to be with people who are asymptomatic. Now with TB, what's often happens is that they think they're asymptomatic, but they're not really. If you quiz a little deeper, then they've got that vague symptom, the cough that comes on and off that they didn't think too much about. Only until it got to the coughing up blood, they thought, oh damn, I have something serious. The tiredness, the lethargy, the weight loss, you can never put your finger on why. And so the screening started around the time of the Second World War. A Brazilian physician came out with a technique that allowed the exposures to be made much more readily. In essence, it was like the Polaroid. He made it into a Polaroid type of thing, which increased the turnaround time, which increased the speed of acquisition. The pictures were available. It couldn't just simply be a fluoroscope where you looked and that was it and remembered. For screening, you had to have that picture and you had to view it in the view box at your leisure. So that was the turning point. But what was happening after the Second World War was that the yield was getting progressively lower. So by the time it was 1956, the pickup of asymptomatic TB was about 1 in 481. And people were talking about the cost effectiveness of the screening program. The WHO wasn't terribly impressed. There were lots of problems that were inherent in the technology itself. For a start, there was a lot of inter-observer and also intra-observer variability. So one radiologist would say TB, and the other one would say no TB. One would say TB on Monday, and the same one would say no TB on Friday. And it's easy to laugh at radiologists, haha, they can't even agree with themselves. But what it's really a sign of is that perception of any abnormality depends on how obvious that abnormality is. It's an obvious point to make. But when things are very subtle, you're going to have variability because there's no exact science how subtle things should be perceived. Remember, it's perception. So low specificity, high variability. The WHO, and in a kind of patronizing manner, with a little bit of paternalism, the Anglo-centric paternalism, thought that we can't let this technology be let loose in India and other countries like India because it would be misused. How would it be misused? Then people would treat patients purely on the radiograph itself, and rather than have microbiological confirmation. And so they recommended sputum. That sounds like a very good idea, sputum, but it's not that easy because first of all, you have to have lots of bacilli in the sputum for the sputum to be positive. It's kind of a spectrum thing. The more infectious you are, the more active the TB is, the more likely it's going to be positive. And it's precisely in those that are towards the asymptomatic side that the sputum is falsely negative. And the other thing is that it's very, even if people cough, it's not the greatest thing in the world trying to produce sputum. It's not very decorous, and it can be easily mistaken for saliva, and you have to get the stuff really from deep inside the chest. And so the yield of the sputum wasn't that great, and it was very frustrating. Unlike other bugs, the Mycobacteria TB is very slow on the medium, the culture medium. Although it's gone a bit faster, it used to be traditionally 3 to 6 months, and by that time, you're kind of, if you have disease, you're in advanced disease, and if you don't have disease, then you're just flapping around getting worried if you have the disease or not. And so the specificity was improved by nucleic acid amplification test, which has a specificity of 98%. Now, this is not 100%. It still has a slight sensitivity problem, but it has another problem, which is the cost. And also you do this on the sputum. So the cost problem and the fact that you have to do it on the sputum, but still it is much more sensitive than the actual sputum. Actual sputum microscopy. So there are lots of problems. And on top of that, you can't treat people with TB frivolously. You can't just say, all right, let's treat them empirically. And if we find out they don't have TB, fine, we can stop that, because you can build up drug resistance that way. And that's why TB compliance and concordance is a very important thing, to the extent that you have directly observed therapy, which is sort of the healthcare version of Big Brother looking at what you're doing. But let's look at WHO's goal. WHO's goal means that you have to get to populations that you don't normally get to. So the easiest way to get to anybody is by putting a screening equipment in the hospital, because ill people get to the hospital, but people that are well, to get to them, it's like diminishing returns. You have to go into the community, you have to go into the slums, you have to go into the villages, and these villages, they are all over the place. They are 100 to 200 miles interior into the country. So this is a challenge that is a challenge of both the technology, but also access to the technology. And that's where the X-ray van returned, the same van that what started off as the mobile unit with Curie, that became the X-ray van that went around, like the ice cream van that goes around. And now you have that returned. And that's where we are presently. Still has a problem. And the problem is, okay, so you get to the people, you take their pictures, and what do? You need to get a read. You need somebody to read it. You still need somebody to read it. And who's going to read it? It could be a physician, or it could be a radiologist. But even with a radiologist, there aren't enough radiologists. And with physicians, there aren't even enough physicians to be in rural India to read this. So we're talking about a huge volume. Remember, when we say that the deaths from TB are 1.6 million per year, it means that the cases of TB are going to be much more than that, which means that the people that need to be screened will have to be more than that, because if you knew who had the cases, you wouldn't be screening. So the net really has to be thrown very far. So the method that's used right now is a combination of the chest radiograph, this is a highly sensitive test, and a very specific test, that is the gene expert. So you throw the first net, which is the chest radiograph, and everybody that tests positive, you say, now I'm going to throw the second net, which is the nucleic acid amplification. So when the chest radiograph says no TB, has a very high negative predictive value, it means very low chance of there being TB, as good as saying no TB. And when the gene expert says TB, it doesn't lie. There's no fake news there. So that combination is what's best, but still you need somebody to read it. So that's where these vendors came in, and their rationale was that, instead of trying to replace these radiologists, where, which is a very, very big goal, there's no point trying to do that in India. In India, in Pakistan, in Philippines, in Africa, where there are not that many radiologists, where all the radiologists in the metro place, why not just give a supply of radiologists? That was the rationale. And then the second rationale was, what disease should we look for? Screening was the most obvious thing, and TB was the most obvious thing. So this was a confluence of many factors: entrepreneurship, public health, need, and logistics. Put it all together, and that's where you have that. So this is a process familiar to all data scientists. I'm just recapping it to tell you how the algorithm matured. So the vendor went around getting lots and lots of chest radiographs. In total, about 2.5 billion from various hospitals, mostly in India, but across the world as well. A certain number were taken for training and validation. And then the test was put aside. And of course, this is done to prevent overfitting. And this is something that actually radiologists have a problem as well. The idea of overfitting is that you can be so geared up to the institutional nuances, like the pretest probability of disease, the spectrum of disease, and also the technology itself, that when you get put away in another institution, you tend to kind of flounder a bit. And algorithms have that problem, and we have that problem too. I'm in a tertiary care academic institute, which has very high level of high yield for pathology, because we have a transplant service, we have a bone marrow transplant, a big oncology service. So that what I see is very different to what somebody in practice in a trauma center might see. And if I were put in that trauma center, I'd have some issues adjusting, and that's the overfitting problem. When a radiograph comes, it comes not just with the images, but a report. And any of you that reads radiology reports knows one thing that we're very famous for, aside from hedging. We're very famous for variability in how we express ourselves. We use the same word, opacity, to mean different things. So 3 different radiologists could mean 3 different things by opacity. One might mean pneumonia, and the other might mean just atelectasis. We use different descriptors to convey the same thing. One might say infiltrate for pneumonia, one might say consolidation. I tend to say consolidation. Infiltrate just strikes me as a word that shouldn't be used. But where did I come? What is the consensus? There are certain consensus, like we have a Clinician Society that has a consensus. But the point I'm going to make over here is that when the vendor first encountered all of these, there was this despondence just looking at the radiology reports, saying, "Oh my God, how are we going to know what this chest X-ray, what's this radiologist actually trying to say?" It's been taught that you cannot train an algorithm without the ground truth. And here on the chest X-ray, it gets very complicated, because in the chest X-ray, there are lots of levels of truth. So when I'm reading a chest X-ray and I see a consolidation, one level of truth is the consolidation, right? So that's a ground truth as well. Another level of truth is, what is that consolidation due to? Because you don't treat consolidation, you treat the thing that caused the consolidation. And that pneumonia, maybe, or maybe it's a pulmonary infarct. So what do you use as the ground truth? Do you use the consolidation, the descriptor, or do you use what that descriptor denotes? And there are problems with both. If you use just the descriptor, then you'll never get down to beyond just the descriptor. You'll never be able to say pneumonia, all you'll be able to say is consolidation. But if you use what the patient actually has, there are 2 problems with that. The first is, when we say pneumonia, it's not really certain that the patient has pneumonia. There is very little external verification what the radiologist says. You can look at the EHR and go and say, okay, I think this patient had pneumonia because they were started on treatment and they got better, but you don't know if that's just simple evolution of the finding. But we don't rip the lungs out and look for biopsy. The other problem is that different things can look the same on the chest radiograph. So even if we say consolidation for pneumonia, consolidation from a pulmonary infarct can look exactly like that. The other problem is that the more truth that we have, like if we really go down to the specific cause of pneumonia, Legionella pneumonia, the smaller the sample size will be, and then you have issues with generalizability and confidence interval. So the vendor decided that they would, instead of going for the whole truth, they would go for descriptors, the radiology descriptors, and they came out with a bunch: blunted costophrenic angle, cardiomegaly, cavity, consolidation, fibrosis, hilar enlargement, nodule opacity, and pleural effusion. Again, I think these were reasonably different, reasonable descriptors. There's some difference, like For example, cavity and nodule are not necessarily the same, although you can have a cavitary nodule. It gets a little complicated. Is that a cavity or is that a nodule? But by and large, I think these are ones that stand on their own. What they then did was they developed their own NLP that looked at the free text of the reports that came with the chest radiographs to flag these descriptors, because otherwise they'd have to go and look at every single one of them and say, okay, so this said consolidation, this said opacity, and with 1 million they'd be here for the next 30, 40 years through multiple AI winters. So they went and used an NLP for that. Now here are some interesting things, because here you'll see how radiologists behave. That can tell you, or rather how the algorithm performs tells you a little bit about the radiology behavior. So the NLP was tested. Before they went around releasing the NLP on 1 million studies, they tested it on 2,000 to make sure that the NLP was actually flagging these descriptors correctly. And if there was an error, that error was scaled out of the, out of the box. So to give you one example, NLP did reasonably well with sensitivity specificities all over 94%. One example was the sensitivity and specificity of normal and abnormal. The sensitivity of abnormal, like when the NLP said abnormal, how often was it really abnormal, was 94%. And the specificity was 100%, which means that sometimes when the algorithm picked up abnormal, the radiologist really meant to say normal. So what does that mean? It's actually very interesting, because we tend to use more ambiguous weasel words when we're describing normal than when we're describing abnormal. In fact, when we think something is really abnormal, our language becomes less ambiguous. But we're like, do I really want to call this normal? But I don't really want to, but if I have to, can I just say that the lungs are prominent or something like that? And those weasel words that we use confuses the algorithm. So how we perform ultimately determines, as you can imagine, how the algorithm performs. Algorithm cannot perform better than radiologists for this particular reason. One other area which I thought was quite interesting was the costophrenic angle. Costophrenic angle is the place where the lung meets the diaphragm. It's like a very sharp interface. And it's generally sharp, but often it isn't. It's a little blunted. And why is it blunted? Well, one of the reasons it's blunted is because there's the pleural effusion, there's fluid over there that shouldn't be there. The thing is that I can tell you that, in an average day, if I were to look for a blunted costophrenic angle, I'd find it in 30% of people. And that doesn't mean that 30% of the world has a pleural effusion. It just means that it's a very, very poor sign. When it's really sharp, great. But when it's blunted, meh. When it's really blunted, yeah. So this is interesting, because the way radiologists describe a blunted costophrenic angle is so variable. I mean, for me, it really depends on my mood. I can tell you that. Sometimes I go, meh. Sometimes I say pleural thickening. Sometimes I say pleural effusion. There's no consistency. And even if there was consistency, if we all did it in the same way, we'd be all making the same error in the same way. We wouldn't actually, the error wouldn't reduce, which is interesting, because the algorithm prefers that we be consistent. This is one of the places where they failed completely, the costophrenic angle. The algorithm prefers that we're wrong but consistent, rather than some of us are right and some of us are wrong, because that confuses it. So the algorithm starts at a disadvantage. So if radiologists are celebrating AUCs, they shouldn't, because once the algorithm gets a lot and lots of, in its training, gets a lot and lots of data, there are a couple of disadvantages it starts off. With ImageNet, the pixel size wasn't a lot. The chest X-ray pixel size is much finer, which means that if you have a nodule on a chest X-ray, it's not like spotting the cat in the background with a sofa. So transporting AI success in ImageNet to chest radiography was probably one of the big errors made early on by people. If you have a nodule on a chest X-ray, that nodule you can't just ignore the rest of the chest X-ray. Like, for example, if you're spotting a cat, the sofa is immaterial. If the sofa is big or small, cat is still a cat. You don't have to worry about the sofa. Your job is to spot a cat. On the lungs, your job is to spot abnormality. And it's just because there's something in the right upper lobe doesn't mean there's nothing in the left lower lobe. So what they had to do, because the 4096 by 4096 was a bit too much information, they had to compress it to 256 by 256. You're familiar with the jargon, but I'll tell you one thing that happens when you compress things. You lose resolution, as you know. So what happens when you lose resolution? Well, there are structures in the lungs that appear like abnormal structures, one of them being the pulmonary artery. Pulmonary artery is a kind of a long, like a structure that is like a cylinder. And if you cut it at a certain angle, it looks just like a nodule. It can fool anybody, it can even fool radiologists. So AI started at a disadvantage, but AI's weaknesses were the same weaknesses that were radiologists' weaknesses. So AI struggled with the lung apices, and AI struggled with the apices, because that's, you know, where the clavicle and the ribs come through. They struggled at the hilar parts. That's very busy real estate, lots of things happening there. Lots of normal structures can look all normal, just with slight movement behind the ribs. And as I mentioned, the costophrenic angle. So what were the results? So after they ran through about 1 million studies, a fair few training, about 150 to 250,000 validation, they went to the test. And the test was done really kind of with a much more attention to detail. So firstly, the hospitals of the test were different. And the second thing that they did was they actually made the ground truth much more rigorous in the test. So for the training and validation, the ground truth was what the radiologist said. So the radiologist said opacity, and the chest X-ray disagreed, then the chest X-ray was, that was a mark of its failure for the algorithm, the AI. With the test, they got 3 radiologists, and it was a best of 3. So 2 had to agree and 1 disagreed. So if 2 said that there was an opacity, 1 didn't, and AI said the opacity AI was correct, disregarding that 1 radiologist that said that wasn't, so it was a majority rule. And so it reduced one of the problems that we have, it reduced the inter-observer variability. Still didn't get you to the whole truth. As I mentioned earlier on, the whole truth is what the patient really has, and that could only come if you rip the lungs off and sent it to pathology or sent it to microbiology. And so the area under the curve for the test was 0.92. Recall the first slide I showed you, they all did reasonably well at 0.94. So this wasn't that different. What was interesting, and I think, you know, this is one of those interesting things that you pick up and you understand why once you've been reading lots and lots of studies. What was interesting was in the validation, the AUC was 0.86. And generally what happens, because the test is different sample from the validation, and because of overfitting that is almost inevitable, you know, it's kind of built into the system, the AUC falls by a few percentage points. Now, it's not supposed to fall dramatically, otherwise it's no longer useful as a tool. It's supposed to fall by a few percentage points. But here it improved. So why did it improve? And this is very interesting. Because in radiology, we have findings that every radiologist is going to mention. Such as the consolidation, the alveolar opacities, the interstitial opacities, the pulmonary edema, the pneumonia. But there are also other findings that radiologists don't necessarily mention all the time, consistently. So for example, there could be calcification of the aorta, right at the aortic arch. I don't mention it, particularly in an 8-year-old, everybody has it. What's the point? What am I actually conveying by that? Some mention it, some don't. Sometimes the aorta is a little tortuous, a little bigger, a little bit more dilated. It's not that dilated. Some mention it, aortic tortuosity, others don't. So these are gray zone findings. These are gray zone findings, which is very much down to the individual, whether you mention it or not. And these gray zone findings were much more common in the training and validation set than in the test set. Because remember, the test set is much smaller. The training validation set had lots of gray zone findings, and the test set had fewer gray zone findings. And so it did better because it was less confused by those gray zone findings. So gray zone findings, it doesn't know what to say, and it'll get marked negatively. If it says tortuosity and the radiologist is saying no tortuosity, it'll get marked down. And if it does the opposite, it'll get marked down. But if it's not there in the first place, we said, it takes that problem away. This is interesting because this is a problem that radiologists face. Radiologists in the first, when you first start looking at chest x-rays, you have less of a denominator to know what you don't know. And so our reads are tighter, our AUCs are higher, artificially higher, I think, and you appear smarter or more confident. Once you start reading 20 to 30,000 chest radiographs, you start appearing a little insecure. You know what's not there. You know the significance of these gray zone things. So there's more uncertainty, more doubt, and your AUC actually gets worse. And actually, one of the famous chest radiologists said the first 10,000 chest x-rays are easy. And so it means that the AI can never really, it's not just going to keep getting better and better. It's going to reach an asymptote because it'll get better with being fed with more data, but it'll get worse because it'll start seeing gray zone stuff, and those two will start cancelling each other off. And that asymptote is around 0.90 to 0.94, which isn't bad. Don't get me wrong, I think that's kind of, radiologist performance. Another very interesting thing. So whenever you look at an algorithm, it has to be very much context dependent, which means that you could have multiple algorithms for the same modality. How one performs in the screening realm is very different to how one performs in the diagnosis realm. It sounds like the same, but it isn't. Screening, all you're doing is abnormality, no abnormality, abnormality, no abnormality. Diagnosis, you're going a step further. Diagnosis, you're now thinking to yourself, is this abnormality from TB, or is it from some other pneumonia? Or is it from something that's not pneumonia, but can cause pneumonia-like pictures? Discernment is difficult. So researchers, the same set of researchers that looked at the comparison with the first vendors, and these vendors on the TB front have been very good with their data. They've actually said to academic researchers, take it away and find out, even if what you find out doesn't put us in good light. And this didn't put their algorithm in good light. So whilst they were getting AUCs of 0.92 to 0.94 with screening, the moment they transported the algorithm to a different situation where they put it in a tertiary hospital and they said, okay, I'm going to give you 1,000 cases. It was a retrospective study, 1,000 cases. 400 of them is going to be TB and 600 of them is not going to be normal, but it's going to be stuff that looks like TB. We'll throw in a few normals as well, but there's going to be stuff that looks like TB as well. A lot of them will be that, like bacterial pneumonia, like malignancy. Now what happens? Now, what happened was the AUC fell to 0.81. The sensitivity fell to 71%. Remember that sensitivity was around, was well over 95%. Specificity fell too. Well, one of the things with sensitivity specificity is that they have to be taken in concert. And often what happens with the algorithm is that you can tweak a point that you think will yield the maximum sensitivity and maximum specificity, or rather the maximum combination, optimal. Maximum is not the right word, optimal sensitivity and specificity. And radiologists didn't do terribly well either. In fact, they did a little bit worse, with sensitivity of 56%, specificity of 80%. And this is a problem we face a lot in imaging. We are very good at saying whether somebody has a disease rather than distinguishing between diseases. So this X-ray here is TB, right? What's this X-ray here? What's this X-ray here? If anyone tells you, looking at all of 4 of these without any historical context or without any index of suspicion, this is TB and this is not TB, this is in fact Legionella, they're bullshitting. This is COVID, they're bullshitting. This is why early on, the COVID pandemic, there were a lot of radiologists got very excited. We can tell TB, we can tell COVID on the chest X-ray or the CT scan. No, you can't. That's bullshit. And naturally, when radiologists get excited, there's going to be some data scientists who gets excited because they think that AI can do the same thing. No. All of these look like each other. They can certainly tell that they're abnormal, but without context, you can't tell which is which. Context is the key thing. And so I wanted to tell you about what this inquiry and this journey got me to think about. It got me to think about how we radiologists, what we do, and what is our weakness, what is our strength. Now recall that the AUC for radiologists was lower than the AUC for the algorithm. Does that mean the algorithm is better than us? That would be the logical conclusion. No, because there's one thing that we have in the advantage of. We can revise our prediction. We can come up with a diagnosis and then revise it and come up with another diagnosis. And the crucial error that we make, which makes us imminently replaceable, is we give static chest X-ray reports. Consolidation, TB. And X-ray reports should be iterative, dynamic, at least in certain situations where there's a dialogue between the clinician, the radiologist, and questions are asked. Does this patient have an elevated ESR? Does this patient have reduced lymphocytes? Does this patient have a high risk travel? And based on that, based on the back and forth, you come up with different diagnoses. So on a single time point, if it came down to a single diagnosis, the hit it out of the park type of mentality, I think that's where we fail. But if it's more interactive, if it's more iterative, then there is a difference. And I'm not sure that we're practicing in that manner at the moment, or I don't think we're practicing sufficiently and frequently in that manner. Picking up disease isn't the same as distinguishing between disease. There's a big difference between detection and inference. And I don't want to throw numbers out without empirical evidence, but I would say that radiology is 80% visual and 20% non-visual in terms of coming up with the diagnosis. And you get the drift. You don't have to worry about whether it's 80-20 or 90-10, but a lot of it is non-visual. This inquiry of mine into TB it's kind of been a little kick up my own perspective, woken me up in terms of what AI can or can't do and what we can or can't do. We have a scenario where there are places in the world which don't have radiologists, and to worry about AI in a very Anglocentric context is, I think, not only does it show lack of insight, but it's a tad selfish as well. So in India, you have places where the cell phone reached before the landline and even reached before the electricity, because certain technologies diffuse faster than others. And AI is going to be one of them. AI is going to be one of them. And the rate limiting step now is no longer AI. The rate limiting step obviously is not radiologists. And it's not even physicians. The rate limiting step is not AI, it's not the interpretation, it's getting that chest radiograph, the chest X-ray machine cheaply to these areas. And the chest X-rays, the technology is still very expensive. And vendors in this space that can actually reduce the unit cost stand to make a lot of money just because it'll actually just explode. The diffusion will just explode. So it's very much of an augmenter. It's very much of a supplier where supply doesn't exist. So what does all of this mean? I think if you're looking, and I'm sure that people are doing some excellent work in AI in many places, but purely in terms of adoption, in terms of imaging, if you're looking at that, I would turn your gaze to the lower middle income countries. There are 3.8 million cases of missing TB in the world, a quarter of which are in India, and there's no way that's going to be picked up by sputum. There's no way. In order to pick that up, the scale that you need is going to be very, very different. And so what you're going to have, and that's one of that's the way I think it's going to happen, is that you're going to have reverse redistribution of innovation. So traditionally, innovation has come from the United States, Japan, Germany, France, Britain, but particularly the United States, overwhelmingly the United States, and they've gone into India. So it was the United States that first had the multi-detector CT. But not long after that did a entrepreneurial Indian radiologist have one. Here it's going to be the opposite. Here you've got a confluence of public health and entrepreneurship that's going to produce the stuff there, and the diffusion is going to be, if it's going to occur, it's going to go in the reverse direction, not in the forward direction. I think that there's still tremendous opportunity to work with such entrepreneurs in the public health space, because largely because of the experience of Silicon Valley and the hot air that was coming out of it with its technology, vendors actually want academics to take their product and to test it. And they say, look, better you than me, better you than us throwing it to some hospital in India and them finding it a missed thing, and then we lose all contracts. So they want it. And that's, I think, where partnerships can occur. And I think that with the reduction of public health, the low-lying fruits of public health like immunization and sanitation and childbirth, the next level is going to be imaging. We may think of imaging as being a first world problem, but the low middle income countries sooner or later develop first world problems. And when that happens, AI is going to be a big part of it. And I think the way to get involved is to partner with these organizations. And as I said repeatedly, and I refer merely to myself, merely to my own naivety back in 2015, 2016, fear of AI is a decadent first world problem. And it's not, and it sounds like a cliche, but I think we should embrace it because it has many more exciting possibilities for the future. It gives more than it takes away. And it may take away a bit, but it'll give a lot more. Thank you very much for listening.
Thanks, Saurabh. That was a wonderful talk. I'm going to just ask a couple of questions. I think we just have time for just maybe one question, but I do want to ask follow-up really quickly. Where is the status of this technology right now in India and in other third world countries? Have they taken some of this and started to implement it?
Oh, absolutely. So the TB screening is occurring at 3 levels in India. The first level is the municipal hospitals of big cities. So as you may know in India, that there's a huge gradient in terms of quality of care with government hospitals and private practice. Nevertheless, it's been the government hospitals that have taken the mantle of infectious disease screening, like TB screening. And this is where it's really walked in very nicely. The other area that it's gone into, it's diffused into rural India by means of what's known as the dot clinics. So there's a lot of movement in India, largely due to the Gates Foundation, Stop TB, and multiple other USAID and multiple other organizations that have established clinics such as dot clinics in tier 2 and tier 3 cities. And so it's moved there where there haven't been radiologists, and the radiologists have been generally quite happy to say, okay, you want to take over TB screening? All right, it's not knee MRI, so you can go and do that. Since knee MRI is what pays, this doesn't pay. It's moved in areas in Africa, in Philippines, in Pakistan, in Karachi. It's very big. One of the public health guys there, he took out the old van from their Rotary Club, fitted it in with the new chest radiograph, and drives it around. And there's still a lot of respect for the chest X-ray. Its adoption compared to sputum is chalk and cheese, because the X-ray is still viewed with the same mystery that it was in Thomas Mann's Magic Mountain.
One quick question. I know that we're getting to the other session, but I think a theme that was very interesting to me to listen to. I'm going to quote. I wrote it down. Algorithms prefer we're wrong but consistent. It gets at some of the core issues you brought up a little bit later about how, especially in the imaging fields, there's perceptive errors, and then there's a framework of interpretive errors. And it seems like AI might have more application in terms of just making sure that perception is consistent, but then maybe interpretation is still a gap, and that's largely driven by human errors. This is a core problem, like whether or not it's seeing something on a chest X-ray or defining sepsis. For God's sake, you can have multiple clinicians call it different things. I'm just wondering, like, what do you think were larger lessons learned here? Is there even an expectation that we can get to perfection, or if this tool just comes out and helps us even just move the needle a little bit further, there's a value to it?
Oh, I think there's value to it. I think one of the things the algorithm did very well on was cardiomegaly, because it was defined quite precisely as greater than 50% of the cardiothoracic ratio. So, so when it came to the test, the radiologists that were labeling it, there was no gray there. Now, the thing with perception is that, again, it depends on the spectrum. With subtle lesions, the problem here is that AI can't do anything unless radiologists agree on what is minimal or what isn't. And unless you actually have radiologists that are consistently reporting in the same manner, these very small perceptual things, you're going to get variation all over the place, and you're going to have the same problem. And it's because of that variation, because of the fact that you don't have that ground truth that is 100%. Now, if you had a ground truth that was 100%, and there was 100% consistency, AI would have an AUC of 1. And the reason why it reaches the asymptote is because of both the variability and because of the absence of ground truth, a real ground truth. I mean, telling you exactly what there is. And that kind of pushes you to the boundary, where the boundary represents the event horizon. It's like, you may even come up with a law, like you can't get to the speed of light, you can't get to an AUC of 1 with a chest radiograph, precisely because in order to do that, you have to have 2 impossibilities that just simply won't happen. Even if you then had consistency, right? But what about the real truth? So when you then take the algorithm and put it somewhere else that does things slightly differently, it doesn't do things majorly different. The thing with a gray zone is you just have to do things slightly different. Just that slight angulation of tortuosity that is slightly overlooked. And if it happens enough times, your AUC is going to drop. So I think that's data scientists would have a better idea what I'm trying to say. But I'm articulating it from the perspective of a radiologist, that you simply will not get agreement there because it's so difficult to get the agreement. That when it comes to measuring EF, we still haven't agreed where the right atrium starts and where the right ventricle starts at the base of the heart.
No, I agree. So this has been great. It's been fascinating. It just speaks to some of the technical challenges that have been raised in other parts of the talk, but then obviously, it meets the clinical challenges, and I think that's one of the unique things about the application of AI in the healthcare field. So Saurabh, thanks for joining us. I'm going to take a moment now to hand it back to Jenna for our next panel discussion. So thanks again.